It's very nice to be back here in Athens. The very first course I did with Emmanuel was 28 years ago in Rhodos. We did a course, but that was 28 years ago. And hopefully we will be able to do some more courses there. As Joe mentioned, much of what we do now is on the e-learning. We've taken all our courses, all 114 that we had at University College and the University of London, and we've put them onto the internet as e-learning. It's a 10-hour course, and we have a basic course, and most of Joe's lecture, and my one, is from that. And we have an advanced course coming up, probably released in September. Okay. Emmanuel asked me to do why and who, and in my old age I thought, why, who, and how. I'm just going to do why and who do we treat, and Emmanuel will do how do we treat. Let me see if we can do that. The aims of any treatment for pre-malignancy are obviously to prevent cancer. And that means monitoring low-grade disease. If we have a woman who has, say, mild disease, low cell disease, but a positive HPV, say type 16 or 18, she needs following. Obviously, as we'll see in a minute, if she has histological confirmation of high-grade disease, she needs to be treated. And also, if she has had treatment and she still has, say, a positive smear, a positive HPV, even though she may have a negative smear, we need to follow her. So the major one is to prevent cancer. And then in young women, as we'll see at the end of Emmanuel's lecture, the adverse obstetric outcomes that we have, the bigger the excision, the more likely she is to suffer from premature labor, premature rupture of membranes. But it's not all due to taking a big piece of the cervix. We now know in the last 2 years that it may be related to the healing of the cervix after the excision, and also the fact that the microbiome, the microbiological vagina also is of influence. But again, we know the bigger the excision, the worse the outcome. So that's why we use colposcopy to avoid taking too large a sample. Now, before we do any treatment, there are certain things that we need to be aware of. First of all, there has to be a good indication. As you'll see in a few minutes when we discuss CIN2, you get a CIN2 biopsy. Is that a valid indication? As you'll see in a moment, you then go on to say, is it P16 positive or negative? We'll show you that in a moment. The colposcopy, as Joe said, must be done. You cannot treat without looking at the cervix. It's like, you know, doing something blind. You really need colposcopy, and you need pathology. You need something there, a valid indication. First of all, again, as Joe showed, you need anesthesia. We do 90% of our treatments are done in the outpatients, in the office. 10% we do in the operating room. As you'll see, we have a video of, say, Annette's here will show you. We can do that in the outpatients department, but it's that little bit uncomfortable. So we would use a sedation anesthetic in the operating room. We need to counsel, and in our advanced e-learning course, we have a whole section on counseling. Counseling the woman with a screening test. When she comes for screening, she gets an invitation, come for a cancer test. It's not. 1 or 2 women in 100 will have an abnormal smear. So there's anxiety with that. There's anxiety walking into a colposcopy clinic. 20 4 years ago, we published the first paper on the anxiety of having a colposcopy. And then now with HPV, what does that mean? The anxiety of HPV, and then the anxiety with vaccination. So we need to talk to our patients and tell her what we're going to do, how we're going to do it. And finally, we need adequate follow-up. We now know if you have a negative smear, a negative HPV at 6 months, you can go back to 3-year screening. It's as good as that now. So they're the prerequisites to treatment. Now, who do we treat? Obviously, if there's a reasonable expectation that if you don't treat her, she will go on to cancer. So how do we know that? Joe and I were involved nearly 25 years ago with the Herb Green case, the unethical experiment in New Zealand, where Professor Green took women who had CIN2 or 3, took a minute biopsy and left them. And surprise, surprise, 30% of these women over 10, 15 years developed cancer. And that's probably about the best experiment, but it was an unethical experiment. So we know that invariably CIN3 high SIL degrees will go on to cancer if we leave it. CIN2, I've already mentioned it and I'll spend time on it, in some cases will go on, but not all CIN2 won't, and very occasionally CIN1 we treat. In those cases, if it's prolonged over, say, 2 or 3 years and you still have low SIL and the anxiety is worse than doing a quick loop, we would recommend that. Now, why is the treatment necessary? Because, as I've said, they're pre-malignant, and this is the answer. This is the Herb Green experiment, a minimum of 30%. In a lifetime, 80% would progress to cancer with a mean time of just 7 years. You have a high pollen count here as well as London. All right, I've spent time already talking about CIN3, where we have completeness of basement membrane. Here we have the top. Here is CIN2, and we have it as high SIL disease. But is it really that? We know from the data, if you look in the data, 43% will regress, 35% persist, an invasion. That's been there for many, many years. But really, is it CIN1 or is it CIN3? CIN2 is in the middle. If you look at the old study, this was a huge study, 2007, from the NIH in the States. They looked at the clinical site. In other words, there were 2 types of pathologists. The pathologist who looked at it, they did this in Puerto Rico, and they then took it back to the States and looked at it. So 43% remained as CIN2, but 29%, just under 1 in 3, went down, and 27% went up. So there were probably half the patients were treated unnecessarily. And you may be familiar, this was released just 3 or 4 years ago. It was a combination of all the colleges, the College of Pathologists, the College of ONG, got together and had this last terminology. And it's no longer CIN2 or 3, it's low SIL and high SIL. And if you have a biopsy and it's P16, and I'll show P16, which is an immunological stain, if they're positive, they're high SIL. If they're CIN2 negative, they're low SIL. And this is the P16 immunochemistry, and you've got a lesion here, but looks like CIN2, but it's not. And as soon as you do P16 there, it overexpresses itself when you have these lesions. That's P16 positive, worth treating. How many of you use P16? I'm sorry? But if you had a CIN2 biopsy, would you go back and have it P16? Not always. Not always, yes. So it's now coming in, and when we do, I'm one of the hospital inspectors, and when we go around, we ask the laboratory, do you do P16? A lot of the time they say, oh, it's a bit too expensive. But to treat someone unnecessary, you know, it's about £400 to treat someone, and P16 costs £25 to do. The other one, if you really want to, you can now use cytokeratin 2, and it shows up as well positive. It's, although it's been out for a few years, there are now many other studies showing that you can differentiate CIN2 positive cytokeratin from those who are negative. So finally, in young women with small lesions, there's a realistic chance of it going on to invasive disease, and as you see, P16 indicates those that will progress. But you should discuss these with your pathologist. A pathologist, as I've just asked Emmanuel, will a lot of the time said, oh, I am so sure it's CIN2, to which you should say, please do a P16 for me. CIN1 to treat or not to treat, I've already mentioned this. What's the evidence for and against? We've had these out for many years now. Many of them will regress. We now regard CIN1 or low SIL as really indicative of a HPV infection, and most of them will regress. As soon as you take a biopsy, you remove most of the lesion, you induce healing, and you induce an immunological reaction, and most of these will regress. And I believe CIN1, you get it, but it's usually associated, if you look further, you'll have high SIL disease with it. You can either observe it or you can treat it immediately. Both have advantages and disadvantages. And the two clinical situations that you have, either you see the lesion there, it's easy to treat, take a biopsy from it. Very occasionally it's unsatisfactory, it's a type 3 cervix, it's in the canal, what do you do? And we'll talk about this later, maybe in the interactive, and something like this, you may resort to doing a HPV. If it's type 16 or 18, you may wish to treat it, but this is a very, very rare or uncommon situation where you have CIN1 in a type 3 cervix. So in summary, the surveillance following and looking after these women is standard policy, but treatment can be offered in certain conditions. I mentioned if it persists year after year, the anxiety is worse than having the treatment. In the under 35s, you have to be very careful because, again, as I've said, the more cervix you take in the younger woman, the risk you then have of obstetrical complications. Colposcopy is a major role in the management of CIN1, particularly in young women. Adequate depth of treatment is essential to minimize risk of residual disease. So you have to balance up doing the procedure and taking a large amount of cervix or risking disease. But again, if you have good biopsy, punch biopsies, you should see if there's anything more than just CIN1 there. And every case is individual. There's no blanket that you say, well, we treat all CIN1. We very rarely nowadays treat CIN1. So really, this is how we treat it, and I'll leave it to my good friend Emmanuel to continue, unless you want me to. No, that's you. Any questions, please?
So we have the blast.
Okay, sure. Okay.